Thank you for being here on a Friday for this lunch series. I do appreciate that many of you are using your lunch time to take in this really important information. So I am just really grateful that you are choosing to spend the time with us. That said,
we lost you again.
can you hear me now?
Yes.
Yes.
Oh, yes? Okay.
Talk fast, so you can.
I'm gonna, right, I'm gonna talk really fast and we're not gonna touch anything. Please leave as you need to if you are on your lunch break. I do not have a hard stop and I'm happy to stay as long as people are interested in talking to me about this topic. I have had a very busy week, as many of you have had. And what I learned from one of my earliest mentors in the field of addiction medicine was modeling self-care for the folks that we serve. So I'm going to invite us, especially after all of the technology incidents, to center ourselves and just breathe into this space that we're going to share. We know from a neurobiological level that the practice of gratitude also changes brain pathways. So as a second piece of my mental health, I want to acknowledge with gratitude you for coming here. I want to acknowledge the medical administrator that invited me into her space to work on this program. I want to acknowledge all of the people who have been doing the work and are joining me in this work. And I want to acknowledge the folks that are allowing us to serve them. So why am I here as a physician talking about medication-assisted treatment and addiction? I am here because we know that substance use disorder does have a physiologic component. I am here because I am unfortunately one of the very few people board certified in addiction medicine in this county. And I'm here to do this work wearing my white coat, which I do frequently when I'm giving presentations and when I'm meeting with patients, not to set up what sometimes can be the patriarchal hierarchy of a medical system, but as a reminder that medical folks need to be at the table when we are talking about substance use disorder. We have had many, many, many wonderful, caring folks, peer support specialists, therapists, counselors, family members, trying to help these folks with this very stigmatized disease. And I just want to remind us that the way we will really get those folks moved to treatment is not forgetting the biological, the physiological component of this chronic brain disease. So I want to start with my clicker. Yeah, if you could go to the next few slides. Okay. You want that one? Okay. So I want to very quickly just remind, folks about some addiction medicine basics before we get started. Looking at the folks in the Zoom audience at home, I know that most folks are familiar with some of these concepts, but if we are going to talk about addiction medicine, I want to remind you that many of the substances that folks use do create a tolerance, which means that they have to use larger and larger amounts of that substance to obtain the same effects. With tolerance, oftentimes we'll become dependents. In other words, with those higher and higher amounts, folks have to have that amount in their system, or else they will face biologic consequences, which we call withdrawal. And I think many folks are familiar that there are withdrawal syndromes from some of the substances we're going to talk about. In particular, in the field of addiction medicine, we talk about withdrawal from opiates, alcohol, and a class of medications called benzodiazepines. Part of the component that the medical field, the clinical folks can offer folks who use substance use, who have substance use disorder, is offering medically supervised withdrawal management. A lot of folks in the lay public call this detox or detoxification. Detoxification is the removal of a substance from a person's body. But I want to be very, very, very clear that detoxification alone is not treatment for substance use disorder. But there are many, many things that we can do to help folks not suffer through what can be very distressing withdrawal symptoms when they are coming off some of these substances. We do believe that addiction should be treated as a chronic disease. We know that it causes changes in the brain, physiologic changes, and therefore addiction as a chronic disease model is what is accepted by many in the medical community, though not all. We know that it is a chronic brain disease, and I talk about it having bio, psycho, social, spiritual components. So what I talk to my patients about is, yes, it's good for you to get back connected with people. Yes, it's good for you to work on behavior change. But what addiction medicine can offer through the use of the evidence-based medications is help with some of those very real biologic pieces. These biologic pieces, aside from the withdrawal that we've talked about, can also include cravings. Cravings are a biological issue, not just somebody wanting whatever substance it is they're using, but actually craving it. For folks who haven't used substances, it's very hard to understand what this feels like, but it's kind of the analogy that I've heard before is that it's kind of like if you're really, really thirsty, needing a drink of water. So that's what cravings are about. We can come back to some of the addiction medicine basics if there are questions, but I want to jump into what we kind of call the jail project. So we now have in Spartanburg, as a branch of our behavioral health task force, a group called the Recovery Coalition. And the Recovery Coalition began working about a year ago on working to decrease deaths related to the opioid epidemic. We know that in 2022, which is the last time data was available, at the time that I looked last, there were 154 deaths due to opioid overdose in that year. That was a 440% increase. And all of these deaths, I want to point out, are totally preventable. These are preventable deaths. So our recovery coalition began working with this document that I just love the title of. It's Evidence-Based Strategies for Preventing Opioid Overdose. What's working in the United States? Don't you love to get something that says what's working? And so we started looking at all of these strategies that were preventing death. And the highlight of most of these is that medication or treatment for opioid use disorder saves lives. At around the same time, throughout the nation, the opioid settlement funds were becoming available. I know I'm talking about a lot of different topics and I'm trying to have time for questions at the end. But if you are not familiar, the opioid settlement funds are the funds that were paid by the largest pharmaceutical companies and perpetrators of the folks that started this last substance epidemic in our country. And so the way these funds are being dispersed is through county and city governments. Spartanburg County is the fiduciary to about $7 million in funds over a 12 to 18-year period. For those of you that work in grant funding, you know that that's a huge amount of time to have money that could be available. So within South Carolina, I am also very grateful that South Carolina actually came up with a list of approved uses to focus on accountability and oversight of this funding. And I am so grateful to Spartanburg County, who came to the Recovery Coalition, the professionals and volunteers working in this field, and said, what would be the most impactful way to use this money? What are things that are sustainable? What are things that can really make a difference? And how can we measure this? So if you are not familiar, the core strategies that are approved uses are available, and I do have a reference slide, but they're very clear how this money can be spent. I will, as a side note, say that in other states, it has not been quite as clear. And there are other states that are using this money to buy police cars, tasers, drug dogs. You know, yeah. So I am really grateful again that South Carolina was very clear about how it can be used. This is the list of the 9 core strategies. And the group that came together to look at what would be most impactful, what we noticed is that of those 9 core strategies and of the ones that directly affect patient care, there were 2 areas that were not being met at all. And the first of those was treatment for the incarcerated population. So up until last year, there was no treatment for opioid use disorder if folks were incarcerated here in Spartanburg County. So why would we want to treat in the detention center? When we were looking at the numbers, there were approximately 650 inmates over an annual period that identified themselves as having opiate use disorder. 90% of the inmates in our county detention center do return to the community. So 10% do go on to other correctional areas, but 90% of these folks come back and are here in the county with us. And the other thing that we know is that on the average, folks who are incarcerated across the country tend to have more severe disease. Forgive the expression, it's a contained population that you can really bring treatment to and really make a big impact. So that was the thought about bringing treatment into the jail. What we know about medications for opiate use disorder, that's what MOUD is in the jail is that when you force people to withdraw from their opiate treatment, which was the case up until this program started, they are less likely to re-engage with treatment after they're released. We know that it decreases drug use, it decreases syringe sharing, it decreases criminal activity. In decreasing the sharing of syringes, we're decreasing communicable diseases. It does increase treatment on release, much, much higher than psychosocial treatment alone, just counseling or meetings. And the thing that troubles me is that overdose is the leading cause of death when folks are released within the first month. And that has in part to do with tolerance, because if they go back to using, they are at much, much greater risk for overdose. And this goes the same for places that provide non-medication housing options, ask people to come off their substances and then release them. They're also at very high risk for overdose. So, of those approximately 600 inmates needed released into the community, what do we need to make this program successful? And what is a success? We are going to have to see an expansion of community providers, and we're going to have to see an expansion of the wraparound services, which is also one of the core strategies, which include, according to the core strategies, housing, transportation, employment, and childcare. I was excited about doing this work because I was hoping that it would push all of our community partners to step up to help receive these folks. So we submitted an initial request in August of last year that included the two core strategies that it addressed most were the treatment of the incarcerated population and the expansion of warm handoff programs. We received a little over $2 million in October and began this program. We have submitted a second proposal, and we literally just heard this week that it was approved to expand the program that we're already working with to treat the incarcerated population by adding 4 additional nurses to the medical staff and 2 additional what we call care navigators or reentry specialists within the jail. Another piece that we asked for this time that I personally am I'm excited about all of it, but so excited about was the evidence-based data collection and research. And we have partnered with a criminal justice team over at Spartanburg Methodist College that is going to assist us in doing the outcomes tracking. And that is just going to be fantastic. We also are trying to continue to expand the warm handoff programs by having another community. So we have reentry folks in the facility, and we also now want to have folks outside the facility that we call care navigators that help people get connected with the services that they need. And then the county did add a couple other prevention programs. So within the jail, the pieces that we are currently working on is the daily administration of medication. Some of these medicines are a controlled substance, and administering those kinds of medications in this kind of setting can be challenging and has certainly been a process that we have had to think through carefully. We are also now, our goal is to capture folks when they arrive at the facility with correct, accurate screening for substance use disorder. And then if they need withdrawal management from any substance, or further treatment, typically for opiate or alcohol use disorder, getting them started on that treatment. Eventually, we hope to treat the folks that are currently housed in the jail, but we have been step by step kind of doing this process and decided that we really needed to focus on making sure as folks were coming in that we were correctly identifying. And of course, the whole reason that we're doing all of this work is not because it's easy or fun to treat people in the jail, but because we are wanting better outcomes for them on release. So our big focus is making sure that when these folks are entered into treatment, that they can continue their treatment on release. And I got these numbers from the medical administrator just this morning, and I was super excited to see these numbers. We talk a lot about this project, you know, how do you do something that is so big? How do you eat the elephant? And I feel sometimes like right now we're trying to get the elephant to fly. And I hadn't seen these numbers until she sent them to me, but since its inception, and I do want to, as a side note, say, so our go live date for this program was October 1st. If you live in Spartanburg County and were here on October 1st, you may remember that on October 1st, I was in the middle of a 2-week power outage. And so that's just kind of how this whole program has gone from the beginning. Anyway, since we started at some point in October, we have already screened over 2,000 folks for substance use disorder. And since then, 177 of those have received withdrawal management. We currently have 75 patients in the jail on oral medication and 10 patients on injectable medication. And at this point, in this population, we have had no overdoses or deaths. I would love to give you some more information about, you know, again, one of the big markers is retention and treatment. But we are working, I say to the medical administrator all the time, like, we need everything to happen right now, all at once. And so we're working on getting all of those systems in place so that we can do that kind of tracking effectively.
And the numbers you had there, 75 people in jail, that's men and women.
Yes, correct. Yes, yeah, and that's currently, right, today.
Is that all they can handle in those in detention now? 75?
I will talk to that. Right now, that is pretty close to what we can currently handle with our current staffing. But as I mentioned, we have just increased the staffing significantly. So, some other areas of concern are finding housing for these folks if they need housing. And one of the things that I want to mention again is that one of our I think we all know that we have challenges around housing in general in Spartanburg. But one of our biggest challenges is that we don't have housing that allows medication-assisted therapy as part of the housing, and that needs to be addressed. We do have some community care navigators funded now. I am so excited. That was some of the money that just came in this week. So we're going to have folks outside in the community that serve as kind of a linkage to this care. We are hoping that these folks also have the ability to help us advocate for the expansion of services, vet some of the services that are out there, and make sure that folks fit into what they need for their treatment. It's really important to understand that, as with any chronic disease, there is not a single model that fits everyone. Some people can stop drinking and go, for example, to AA meetings, and that gets them where they need to go. But that doesn't work for everyone. And so we want to make sure that we have lots of options, geographically diverse options, for folks to get what they need. This is just kind of thinking about what we're still working towards. We have the processes in place now. This is a new system. This is a different level of care than what was previously provided at the jail. We need to constantly improve that, make sure that we're not missing anybody on intake, that they're getting the right treatment, that we're getting them what they need. I am so excited. So we have new personnel. We have actually added 9.5, with me being the half, new folks to the medical unit at the jail staff. And this is much needed if we're going to expand their medical program in this way. We still would like to try to get some self-help peer support meetings and recovery classes into the jail. There are barriers around that kind of access. We would like to continue to expand injectable medications, and that's something I could talk for probably an hour about if anybody has any questions on that. And we're looking for some other community partners and continuing to hope that we can have an increase in community providers who are willing to provide this maintenance medication. Once folks are on this medication, you know, the magic question is, how long do people need to be on it? The answer to that is as long as it takes. Studies that look at this question suggest for opiate use disorder that may be about 2 years. Other studies say you should never take people off this medication. I think that those studies are incomplete and don't look at bigger pictures, but for these folks, they need to typically be on some kind of maintenance of this medication while they're getting their job back, while they're getting their relationships in order, while they're getting their kids taken care of, while they're rebuilding a stable life. And once that's in place, then, you know, they may be able to come off, but we need folks that are willing to prescribe. And then here's a list of my references that I'm happy to share or send to folks. And I would like to, I hope we have, yes, we do have some time. I would like to open for any questions.
No, I have one. I am on the board of Angel Stars Ministries,
Oh, excellent.
working with the ladies, and we've been really thinking about all of this, because
I hope so.
our executive director is not quite so sure that she understands all of this, and I hope that she could come, but she didn't. So I'm gonna tell her everything I've heard. And Jamie Gibson, I think you've met her. She's our program manager. She wants it to happen. So we've got to make that happen.
I'd be delighted to speak with you all. Yeah, yeah. You know, the standard of care, the evidence-based care is providing medications for opiate use disorder. And so saying that folks can't be on those medications is not providing the standard of care.
I forgot to announce Elaine left some pies because today is Pie Day and they are for folks who ask questions. So. And there are some comments in the chat.
Oh,
Can you help me with those?
Would you like for me to read them? Okay.
Sure.
So we have, why are you not utilizing community services that exist now that provide counseling, mental health, peer support, medication?
We are using community services now. It has been a slow process to get this program up and running, but we do have other community partners in place. Absolutely.
Could that question maybe also mean, is there an opportunity for existing providers, partners of those services to connect with you?
Absolutely,
Okay. So
absolutely.
that's a great follow-up.
I will say that, one of the. It's tough to get folks into the jail.
Oh, yeah.
It's very tough to get folks into the jail. And we have lots of people that have said, we would love to come, we would love to help. And we have a list of those people. And, part of the barrier around having folks in the detention center is that if you are, clinical staff or someone from the outside, there has to be a deputy, one of the custodial staff, with you when you are seeing any of the folks in the jail.
Yeah,
And
oh, I'm sorry. I was just gonna clarify on the comment that I made. I wasn't talking about people going into the jail to help with support.
could you tell me your name, please?
Yeah, Deborah Voller.
Hey,
Hi.
what you got, Deborah?
Oh, I was just curious. I'm over the MAT department at the Forrester Center, and we have all those services, but we're not getting any referrals. So I was just curious about that.
I can't really speak to the referrals. There are folks that are in place now making those referrals, and I know that you were on their list.
Okay.
Okay? I think you know the people to connect with at the detention center.
I think our peer support has a contact over there. I haven't, had any invitation to be involved directly myself, but I was
Okay,
just
well,
curious. I didn't
I
know.
know that I know that we have some of our community folks have met with Sue and all that, so. The Forrester Center is absolutely involved.
Yeah, that would be great. Yeah.
Yeah,
Who's the person in detention that you would go talk to? And say, "I would like to"?
Deputy Wright has been the person who has done all of the reentry work for the entire jail.
How do you spell it?
Wright, WRIGHT. Yeah, she works with Angel Stars. She knows Jamie.
Okay.
They're connected.
Okay.
Yep. So that's the other piece. As a reminder, we have 4 additional reentry specialists. So we are quadrupling the manpower that we have now. That will start when that money comes through in April. So.
And we had another question in the chat. Can you expand on treating eligible inmates? Does that go beyond individuals that are currently in withdrawal?
So it is absolutely our goal to, as a next step, once the staffing is in place, start focusing on people that are in-house that may need treatment. So maybe not actively in withdrawal, but do meet criteria for opiate use disorder. The conversation around that has been that what we will probably do is start looking at folks, and there is data to support this, who have a release pending. And so if those folks have a release pending within the next month or so, that will be where we will focus next. Again, from a staffing perspective, identifying those people is going to be part of the task of our now expanding reentry specialists. And so we're hoping that we can begin to focus more on that as we get those folks in place.
I'm very curious about, the grant funding because, it sounds like this is something that's been needed and we're making it happen. But, my concern always is what happens if and when the grant money runs out? Now it said, 12 to 18?
So I wanna just clarify the language. It's not a grant.
Okay,
It's
Okay.
not a grant.
Okay.
And that's the difference. This is settlement funds.
yes, okay.
So
Yeah.
this is the second largest legal settlement in our country after the tobacco settlement.
This is awkward.
you know, among others, yes, yeah. So, the concept that I've explained is that this money really should be available.
Ongoing,
Yeah, yeah.
So they will begin induction in jail after withdrawal has stopped.
The current process is that when folks come in, if they are in withdrawal, they will begin induction as we would do medically while they are in withdrawal. Is that?
Shayna asked the question.
Yeah, I was just talking about, kind of expanded on my last question. So, because one of the bullet points you had was treating eligible inmates. So I was just piggybacking off that. So for the eligible inmates, you said, I think it was 500 or 600, you had a question mark. So those individuals would begin, once you move on to those individuals, they'll begin an induction to Suboxone even after the withdrawal has stopped?
Well, if they're in-house and not currently using anything in-house, they would not be in withdrawal, but they may be placed on medication, as is the standard of care for high-risk incarcerated individuals.
Okay,
So that's less of a buprenorphine induction and more a taper up.
okay.
Does that,
Yes, ma'am, thank you.
okay, okay.
So I know, I have been in the detention center once, but I was talking to, Dr. Ken Apple, or Pastor Ken Apple, if he's still there. But, what was I gonna ask about that now? How do you know that, how do you figure, I guess you have someone in there to talk about which people are doing fine and they weren't on drugs, they did something else. And then this group does have a problem.
Right, that's part of the
So they figure
screening
that
that
out.
happens on intake.
Okay.
Yes, yeah. So, very basically, and there's a lot more to it, but one of the first questions that they're asked, even by non-medical staff, is, are you at risk for withdrawing from a substance? You know, and if that answer is yes, that flags them, and yeah. Yes, we are meeting criteria for folks that have opiate use disorder. We're not treating everyone that comes in. Yeah.
Okay.
How can folks get more information about the Recovery Coalition, and learn more about the work that that organization is doing, or group of individuals?
Well, I mean, that's part of the behavioral health task force, so I think, folks that are, involved in that kind of work already kind of know how we meet, and I'm happy to pass on information if there are folks that need to be involved. I feel like we have most of the folks that are doing the work on the Recovery Coalition, but another piece that we're really trying to build with our community care navigators is making sure all of the folks that are doing the work are connected to one another and know what's out there, because a lot of times there are, you know, folks doing something over here, folks doing something over here, and we're not all aware of what the services are. And so having a broader understanding of what's available is gonna help us be able to get folks to the right spot.
Speaking of that, are y'all using like Unite Us or any program for referrals?
Who is this, please?
Joe Panilla Forester Center.
Hey, Joe, yeah.
Hey.
So, one of the things that I'm really excited about, and it was on the slide, about our community care navigators, that included, Unite Us, that included the however many users, for both our reentry specialists in-house and the outside users to connect through Unitas. So yes, and that
Right.
was, yeah,
Of
that was
course.
one of the community resources we were aware of. So we do have that funding now in place.
That's awesome. The Forrester Center is set
Yes.
on Unite Us, so we're
So
good.
I think, again, it's just getting the right systems in place. And I
Sure.
think once if we can get hooked up on Unite Us, and again, that funding will come through in April, that will allow us to better make some of these referrals. I don't want to speak to
Absolutely.
process is right now, but I do know that essentially there was one person for the over 1,000 inmates in the jail sort of charged with, making sure that folks get to the right spot. So I'm super excited that she has more help and that we have things like Unite Us to get into place. This our numbers look great today. This has been a very slow process to get folks started up, to get the medical team familiarized with the processes, to release procedures, dosing, all those things. So we keep saying we are getting there. And hoping to send all kinds of folks over to you guys soon.
Oh yeah, no, we just got hooked up and we're learning the process of Unite Us, and it seems to be a nice referral process from the hospital system and all that stuff. And I know Access Health is hooked into it as well. So I think
Yeah.
more people
Yeah.
that are able to get on it, the better. And it's a nice way of communicating back and forth and closing the loop on the referral process. So I'm excited to hear that. And I think it's going to be a big
Absolutely.
benefit.
Yep, I agree. Thank you.
What
Yeah,
is
of course.
Unite
Thank
Us?
you.
Unite Us is Joe can probably speak more about it than I can. It's a referral software system that connects Access Health, the Forrester Center, the Detention Center. And I know that there are other, like he was saying, the more folks that we can get onto that system, the better the referral system is going to be. And so one of our community liaison that has been working also with the county to do some of, we call it the inside work and the outside work, to do a lot of the outside work, is really trying to get a good picture of, understand who are the resources, where can we send folks. And so that's going to really help get all this connected. So thank you for bringing that up, Joe. I do think that's gonna be huge.
Yeah,
to
absolutely.
get us on the Unite Us.
Just a question about the community navigators. Do they function? I mean, I keep thinking about transportation. I keep thinking about employment,
Mhm.
childcare, all the rest of those things. And barriers to that for
Right.
people, especially coming back, out of incarceration. And so are the community navigators then are they like case managers trying to help
That's, yes.
connect them to all of these things? Because
Yes.
childcare, for instance,
Right,
I mean,
right,
it's a problem for
right.
everybody, but especially for.
Right, that's the idea.
Because we
So
are in society.
up to this point, we do have a little bit of funding in the jail package for transportation, for counseling, and a little bit of money for housing. The caveat again with the housing is the lack of places that will accept people if they do need to be on medication. Although one of our community partners, who currently offers housing, has applied through the SCORE funding, and I encourage anybody interested to think about doing this, has applied through the SCORE funding for another female facility that would accept folks on at least some of the forms of MAT, and hopefully will include housing for pregnant individuals, which would be amazing to have here in town. And so that application went in for the last part of the discretionary funds, so there are two different buckets. There's designated funding, which is county by county, and then there's a discretionary fund that really is open to anyone. That's a little more competitive. But I mean, it's money that's out there. Still needs to meet the approved uses criteria. And so anyway, I'm really hoping that we hear about this partner getting that money for the women's housing, because that would be great. But so this money that is available for 12 to 18 years, we can continue to make requests for this funds as we expand programs. And, you know, for example, our second request, it became almost immediately apparent that we just didn't have enough staff to add this completely different, fairly high volume piece of patient care out there. And so we were able to request the additional staff. So I suspect that in the future, we're gonna try to continue to focus on, okay, transportation, what do we need? What does that look like? What do we need to get covered? You know, and also getting with the right community partners. The Forrester Center, to my understanding, has lots of funding available and can transport their patients. So that's gonna be great when we can get those referrals in place. Yep.
And what's the name of that? Again, the S.A. something.
The South Carolina Opiate Recovery Fund. We call it SCORF. SCORF, yeah.
Okay.
Yeah.
Thank you.
Mhm. And like I said, they have a website and they have the approved uses and a PDF, and you can look all through it, and housing is absolutely in there. So.
But you can serve the people with other forms of addiction other than just the opiates.
This funding really covers opiate use disorder.
Okay.
Now, in order to find opiate use disorder, we need to screen for all of the substances. And as an addiction medicine specialist, I'm not gonna say, oh, you're in alcohol withdrawal, never mind. So we have beefed up and improved all of the withdrawal protocols at the jail. This funding, yeah, specifically is for opiate funding. I mean, one of the greatest boons we have added a nurse practitioner to the jail who is focused solely on the MAT program. Her background is psychiatry though. And so this money is to be used for opiate funding. This program at the detention center is elevating all of the care there. So.
Well, I'd just like to thank you for coming, Dr. Fritsche, and in honor of Pi Day. Please
Pi
accept
Day. Oh, thank you so much.